All right, if you're on a GI or hepatology rotation, you're going to want to pay close attention. The AASLD just dropped a major new practice guidance for portal hypertension and varices, and honestly, it's a game changer. We're about to break down all the high-yield, practice-changing points you absolutely need to know, so let's just dive right in.
So here's the plan. We'll kick things off with a huge paradigm shift in how we even think about this disease. Then, we'll get into the nitty-gritty of how to find the patients who need our help the most, how we can actually prevent them from getting sick in the first place, and of course, what to do when that terrifying emergency bleed happens. We'll also touch on those really tricky gastric varices, and we'll wrap it all up with the key takeaways for your very next shift.
You know, at its core, this new guidance isn't just some minor update. It's a totally fundamental shift in our entire strategy. We are officially moving away from just waiting for problems to happen and instead getting way out ahead of the disease.
And this slide just lays it out perfectly. The old way, totally reactive. We literally wait for varices to show up, scope pretty much everyone to find them, and then only then treat to prevent a first bleed. But the new paradigm is all about being proactive. We want to identify that high-risk state. It's called clinically significant portal hypertension, or CSPH, as early as possible using non-invasive tests. And the goal itself has gotten so much bigger. We're not just trying to prevent a single bleed anymore. We're trying to prevent that very first decompensating event, period. Things like ascites, we want to stop it before it even starts.
Okay, so that sounds great, right? But how do we actually do it? How do we find these high-risk patients without scoping everybody or doing these really invasive pressure measurements? Well, the new guidance gives us a whole new set of tools.
First up, there's a new term to get used to, AASLD. That stands for Compensated Advanced Chronic Liver Disease. Think of this as our new starting population. It's a way to flag patients who are getting really close to cirrhosis, using things like liver stiffness measurements, all without needing that liver biopsy to prove.
And inside that big cow group, we're hunting for CSPH. And the crucial point, the magic number here, is the pressure, 10 millimeters of mercury. See, once the portal pressure gradient hits that number, the risk of decompensation just goes through the roof. This right here is the therapeutic target we are now trying to find, non-invasive.
And this is how we do it. This algorithm is straight from the guidance, and it shows how we can use two really simple, non-invasive tools, a liver stiffness measurement from something like a FibroScan, and a basic platelet count to stratify our patients. So let's break down the key numbers you need to know.
Okay, this slide right here, this is your new clinical cheat sheet. You can confidently rule in CSPH if the liver stiffness is 25 or higher. Doesn't matter what the platelets are. If it's a little lower, say between 20 and 25, you just need a platelet count under 150,000. And if the stiffness is between 15 and 20, you need those platelets to be under 110,000. These are the cutoffs you can literally start using on the wards tomorrow.
So now that we know how to find patients with CSPH, what do we actually do about it? Well, the goal is to intervene early, and our number one tool for preventing that first decompensation is the non-selective beta blocker, or NSBB, which now has a much bigger, much earlier role to play.
And the guidance could not be more clear about which one we should be using. I mean, statement number 1 says it all. Carvedal is the preferred NSBB. This is a huge shift away from propranolol and natadol being our automatic go-to drugs.
So why the big change? Well, to put it simply, carvedilol is just a better drug for this job. You see, unlike traditional beta blockers that only reduce portal inflow, carvedilol also has this alpha-1 blockade. It's like its secret weapon. This actually causes vasodilation inside the liver, so it's attacking the problem from a whole second angle. And I mean, just look at the dosing. It's a simple, low, once-daily dose that you titrate to blood pressure, not some tricky heart rate goal. It's just way simpler and more effective.
Okay, so that's prevention. But what happens when prevention doesn't work, or a patient shows up for the first time with a massive, terrifying bleed? Let's walk through the new playbook for an acute variceal hemorrhage. This is critical stuff.
I want you to think about it in 4 simple steps. Step 1, resuscitate, but you have to be smart about it. Step 2, medicate with the right drugs right away. 3, get that scope in the patient. And 4, risk stratify to figure out who needs more aggressive therapy down the line.
So the most important number in that whole resuscitation step is this one, 7. The evidence is just crystal clear that if you over-transfuse these patients, you can actually make their portal pressure worse and lead to terrible outcomes. So we aim for a restrictive target hemoglobin of about 7. That's it. No more, unless there's a really compelling reason, like they're having a heart attack at the same time.
Now, while you're resuscitating, 3 other things need to happen fast. Get vasoactive drugs like octreotide on board immediately to start lowering that portal pressure. Start broad-spectrum IV antibiotics, usually ceftriaxone, because bacterial translocation and infection are a huge, huge risk. And get on the phone to GI. That patient needs an upper endoscopy with banding, or EVL, within 12 hours of showing up. These are absolutely non-negotiable.
After the endoscopy is done, you risk stratify. And for patients who are at the absolute highest risk of rebleeding and dying, we're talking Child-Pugh B patients who are actively bleeding during the scope, or pretty much most Child-Pugh C patients. We don't wait around for them to fail standard therapy. We go for a preemptive TIPS procedure within 72 hours to get that pressure under control for good. This saves lives.
And this flowchart here kind of puts that whole playbook together visually. You can follow the path right from the moment the patient comes through the door, through resuscitation and the scope, and then down the different decision pathways for both esophageal varices and those much trickier gastric varices, which we should probably talk about right now.
Right, so not all varices are nice and neat in the esophagus. Gastric and ectopic varices, they are a completely different animal, and the guidance gives us very specific advice for these really challenging cases.
The ones we really worry about are the cardiofundal varices, those big, gnarly ones at the very top of the stomach. When these things decide to bleed, it is often way more severe, much harder to control, and it's associated with a higher mortality than your typical esophageal variceal bleed.
And you can't just put a rubber band on these things. The treatment options are totally different, and they require some really specialized expertise. We're talking about injecting a cyanoacrylate glue-like substance to basically fill up the varix, or calling in interventional radiology for advanced procedures like a TIPS or a BRTO to either decompress the whole system or block off the vessels feeding it.
Okay, wow, that was a lot of information, I know. So let's just boil it all down into the key practice-changing points that you can take with you on your very next rotation.
Here are the 4 things to burn into your memory. 1. Start thinking about identifying CSPH non-invasively with a FibroScan and a platelet count. 2. In those patients, start low-dose carvedilol to prevent decompensation, not just varices. 3. For an acute bleed, your new mantra is transfuse to 7, give ceftriaxone, and scope within 12 hours. And 4. For your absolute sickest bleeders, think early and get that call in for a preemptive tip.
And this all leads to a really fascinating final question. This entire guidance moves us so firmly into this new era of proactive care, of treating the underlying portal hypertension before the clinical consequences even show up. So the real question for the future is, with these new strategies, can we actually get to a point where we prevent decompensation altogether? It's something to think about.